The topics of our video today are C-1 Inhibitor Deficiency and Hereditary Angioedema. Most cases of swelling and angioedema are not due to hereditary angioedema, and therefore are not due to a deficiency in C-1 inhibitor. The most common type of angioedema is due to allergies, and is often accompanied by urticaria, which is hives. This type can be treated with epinephrine, antihistamines, and corticosteroids. The medication classes ACE inhibitors, as well as NSAIDs, can also cause angioedema. ACE inhibitor-associated angioedema is more common in smokers and African Americans. These patients are usually okay to take angiotensin receptor blockers, or ARBs. NSAID-associated angioedema occurs after ingestion of an NSAID like ibuprofen and is usually accompanied by urticaria. Hereditary angioedema, or HAE, was originally described way back in 1888. HAE comes about due to a deficiency in C-1 inhibitor. HAE is an autosomal dominant disorder, so children with one parent with the disease have a 50% chance of inheriting the disease. Sometimes in about 25% of cases, there is no family history, and a mutation in the C-1 inhibitor gene comes about at conception. These individuals can then pass on HAE to their children. Jerry, a 44-year-old male, presents to the ER with difficulty breathing, swelling of the face, severe gastrointestinal pain, and nausea and vomiting. He reports that symptoms began 2 hours ago and have become progressively worse. Upon physical exam, Jerry showed non-pitting edema of his arms, hands, and face, as well as a swollen tongue and edema of the mucous membranes of the oropharynx. Jerry also reports that between the ages of 10 and 18, he had a few episodes of swelling in the face that would come and go, but didn't see a doctor at the time. Jerry has no other medical conditions except for recently being diagnosed with high blood pressure, for which he was prescribed an ACE inhibitor called Ramipril 10 days ago. In the ER, Jerry was treated with epinephrine and corticosteroids, but these did little to improve his condition. Jerry continued to have difficulty breathing due to the laryngeal edema partially blocking his airway. His blood oxygen saturation levels, measured by a pulse oximeter, continued to drop, and Jerry was starting to get tingling in his hands, and his lips were turning a little blue. The results of Jerry's blood tests came back, and they showed decreased levels of the complement factor C4 and decreased levels of C-1 inhibitor. The physicians diagnosed Jerry with type 1 hereditary angioedema. At this point, Jerry's symptoms demonstrated that the low oxygen levels in his blood were becoming life-threatening. Jerry was given two choices. One, get a cricothyrotomy at a cost of $1,800. Luckily, insurance would pay 100% of this. A cricothyrotomy is a surgical procedure where an incision is made into the airway so Jerry can breathe. Option number two, an expensive medication will be flown by helicopter from a nearby hospital. The total cost for this alternative is $20,000. Unfortunately, Jerry's insurance will not cover this option, so Jerry will need to pay the entire amount out of pocket. Jerry had a decision to make, and he had to make it quick. He had a great fear of surgery, so he reluctantly chose the very expensive medication. C-1 inhibitor is an acute phase reactant made by the liver that circulates in the blood and increases during times of inflammation. The cause of HAE is due to a deficiency or defect in C-1 inhibitor. A main function of C-1 inhibitor is inhibition of the complement system. Without C-1 inhibitor, the complement system is activated all on its own, as C4 and C2 cleavage proceeds unrestrained. This promotes inflammation in the body and increases the risk for autoimmune diseases such as lupus. Despite the self-activation of the complement cascade, levels of the complement factors actually go down in the blood with an acute attack. This is because the complement proteins are being used up when they are activated. C-1 inhibitor also acts to inhibit the activity of kallikrein. Kallikrein acts on high molecular weight kininogen to form bradykinin. Therefore, a deficiency in C-1 inhibitor leads to excess production of bradykinin. Bradykinin binds to bradykinin B2 receptors on endothelial cells and is known to cause endothelial retraction and vasodilation that brings about the edema associated with HAE. Bradykinin also causes a dry cough that is due to bronchoconstriction. ACE or angiotensin-converting enzymes normally break down bradykinin, reducing its effects. ACE inhibitors used to treat hypertension may have a side effect of a dry cough, induced by elevated levels of bradykinin. Since bradykinin is not being broken down by ACE, bradykinin also activates nociceptors, which contributes to the pain associated with HAE. Unlike swelling due to an allergic response, epinephrine, corticosteroids, and antihistamines are not effective for the treatment of HAE. The manifestations of HAE include repetitive episodes of edema in various parts of the body, including the arms, hands, legs, feet, trunk, face, bowels, tongue, or larynx. The edema episodes typically get worse over a 24-hour period, but then subside over 2 to 3 days. The swelling is less common in the oropharynx, but about half of HAE patients can expect to experience laryngeal edema at least once during their lifetime. Also, patients often suffer from severe abdominal pain, as well as nausea and vomiting that comes about due to edema in the walls of the bowels. This abdominal pain is a distinguishing manifestation because this doesn't occur in other types of angioedema. All the edema in the peritoneal cavity greatly increases the risk for hypotension. There is wide variability in the severity of symptoms among patients. There is often a prodrome, such as tingling in the fingers, that comes on before the onset of symptoms. About 1/3 of individuals also experience non-pruritic erythema marginatum, which is a non-itchy red rash. On average, HAE episodes occur every 7 to 14 days, but in some as often as every 3 days, and in others almost never. It is also common for HAE to remain undiagnosed for many years. Several effective treatments have become available since 2008. Before then, the mortality rate for HAE was near 30% due to laryngeal edema and asphyxiation. Stress, surgery, and getting a cold or the flu may trigger an HAE attack. Minor trauma can also bring on an attack, such as that from a dental procedure. Certain individuals may also get edema in their extremities after doing physical activities, such as typing, shoveling, hammering, or pushing a lawnmower. Fluctuating or elevated hormone levels associated with conditions like menstrual periods, pregnancy, or even breastfeeding also increase the likelihood for an attack. As with the aforementioned case study, treatment with ACE inhibitors results in an increase in bradykinin levels that may also bring on an attack. Before prescribing an ACE inhibitor, a thorough history should always be taken. The age that HAE patients develop symptoms varies, but about half have first symptoms around age 7, and 2/3 of patients are having symptoms by age 13. There's an increase in the frequency and severity of attacks with puberty. The most common type of hereditary angioedema is type 1 HAE, which accounts for 85% of cases. This type is characterized by low levels of C-1 inhibitor due to decreased amounts being secreted. Type 2 accounts for most of the remaining cases. This type is characterized by normal or increased levels of C-1 inhibitor, but the C-1 inhibitor doesn't work properly. Type 3 is the rarest form, and patients show normal levels of C-1 inhibitor. Type 3 is more common in women and is influenced by estrogen levels and oral contraceptives. Patients with type 3 have increased kininogenase activity, which causes bradykinin levels to rise. Some type 3 patients also have a mutation in the gene that codes for coagulation factor 12. Factors of the complement system differ between the 3 types of hereditary angioedema and aid in diagnosis. Pause the video to review the differences in levels of complement components. Androgens like danazol have been used frequently in the past to prevent HAE, but unfortunately they are not tolerated very well by women and can cause liver issues. Furthermore, androgens should not be used in children with HAE. There are several newer products for HAE prevention and attacks. C-1 inhibitor concentrates are derived from filtered plasma donations or from recombinant DNA technology. These products replace deficient levels or dysfunctional C-1 inhibitors. There is also a B2 bradykinin receptor antagonist, known as icatibant, that blocks the effects of excess bradykinin. Another medication known as ecallantide inhibits the enzyme kallikrein, so less bradykinin forms. Another medication, lanadelumab, is a monoclonal antibody that also targets kallikrein to reduce the cleavage of kininogen and consequently the amount of bradykinin. These three medications are administered subcutaneously. To summarize, hereditary angioedema is a disease characterized by a deficiency or defect in C1 inhibitor. Three types of HAE can be distinguished by levels of complement components. A deficiency of C1 inhibitor leads to increased bradykinin levels. Bradykinin causes endothelial retraction, which causes edema. Edema causes the abdominal pain, nausea, hypotension, and more. Laryngeal edema is the most serious, as it can compromise the airway. Attacks may be triggered by stress, surgery, a cold, minor trauma, physical trauma, fluctuation in hormone levels, and ACE inhibitor medications. Treatment consists of replacing deficiency C1 inhibitor levels or using medications to decrease or block bradykinin levels. Now for some questions to assess your understanding. Pause the video now and select your answers. If you answered the following, you are correct. Thanks for watching.